Good morning, I'm Deborah Sims. I'm a CLL patient from Melbourne in Australia, and I'm joined by Professor John Seymour, who's the Director of Haematology and Professor at the Royal Melbourne Hospital here in Melbourne. And we're supposed to be in Frankfurt this week for the European Hematology Association meeting, which sadly, because of COVID obviously, is all being done virtually. But John and I have been keeping a track on things, and we're still very keen to bring the latest data to patients. So we'll go through some of the abstracts that have been delivered on the other side of the world. John, Morano, I feel like I've talked to you for years about Morano, and quite rightly, Morano was the main study for the approval of the FDA approval of venetoclax. And we are still seeing longer and longer results coming out of that. Now, Morano has been discussed at EHA this week, in particular with dose reduction of venetoclax. Would you just talk through that paper?
Yeah, thanks, Deborah, and hello to everyone, and hope everyone's staying well, but keeping your medical appointments and keeping on top of your monitoring and your medications. So stay well, but keep in control of things. In terms of Morano, yes, so this was a comparison of venetoclax and rituximab compared to bendamustine and rituximab, and it showed the superiority of venetoclax, and many of the analyses now are looking at different issues around minimal residual disease, different molecular subsets, and this particular abstract was looking at the impact of either interruptions where somebody needs to cease drug for a period of time, or dose reductions where the recommended dose is 400 milligrams, but in a stepwise fashion some patients reduce to 300 or 200 milligrams, and then potentially permanent discontinuation. So those three potential modifications. The intention was 2 years of the venetoclax, and this is the first analysis that had looked at the impact of those changes. And to me there was some surprise there. Having been involved in the study from the early days, we saw responses at very low doses, but the more durable responses seemed to require the 400 milligram dose. That was our impression. But Morano has shown different outcomes. So the reassuring things that temporary interruption, so if somebody has an infection or needs surgery for something, or hopefully not, but if they run out of medications and can't get them for a week or so, and that's undesirable, but those temporary interruptions did not have an impact on the durability of control of the disease in the long term, provided that patients got back on the drug. Similarly, and again, we don't encourage it, and the majority of patients tolerate the 400 milligram dose well without major problems, but occasionally, and it tends to be low blood counts, neutropenia, so low neutrophil count, if it's associated with infection, or if it doesn't recover despite a few doses of GCSF to stimulate the neutrophil count. If doses were reduced, again, we didn't see any impact on the long-term outcome. Where we did see a reduction, so an impairment, less favourable outcomes in the long term, were if people stopped the drug altogether before the full 2 years of treatment. So slightly different messages. Temporary interruption is okay. Dose reduction for necessary reasons appears to be okay, but stopping earlier than the 2 years is associated with a shorter period of disease control. So that gives good information and far better evidence to be able to talk with patients around, well, what side effects are tolerable? What do we ask you to try and put up with? What things do we justify a reduction? And so we've got some comfort around what are the things that are safe to do, what are the things that we might ask patients to grit their teeth or put up with things a little bit longer to get the optimal long-term outcome.
And temporary, how long would a dose?
Yeah, really good question. And we actually broke that down. So the longest interruption that any patient had was 91 days, 3 months. That was the very longest. But we looked at it by 1 to 7 days, 8 to 14 days, 14 to 21, up to 28 days, and we couldn't see any evidence of any emerging impact with the longer interruptions. Again, which surprised me.
And was when they returned back onto venetoclax, were they having to do the ramp up again?
And that is one of the important questions. So interruptions, my personal preference in the early phase of the ramp up, so beginning at the 20 milligram and gradually getting up to 400, if there is an interruption there, the complexity of, well, what dose do we need to begin at? How closely do we need to monitor the blood counts? Do we need to bring you into hospital to check? Do you need intravenous fluids? All of those really important management issues to ensure the safety become all a little bit more complex if you've had an interruption of more than a day or two in that first 5 to 6 weeks. So even though this is reassuring about the safety, in terms of the logistics and the practicalities, my own personal preference is to try and avoid those reductions in the first months of treatment until we've got very good control of the disease, very good shrinkage, and then if somebody needs to be off drug for a week or two here or there for valid reasons, we then don't have the concern around, is there a risk in resuming again?
Really interesting. And the longer we go, I mean, Morano, how many years are we out now with Morano?
Average 4-year follow-up.
Yeah, and last time, because I obviously have spoken to you at ASH and EHA every year on this, last time I think the people had been off drug longer for the first time, I think that was last year, and how are people doing? I know this data hasn't come out at EHA, but are people still doing well off drug?
So the last update was at ASH last year, and I presented some, and Anne and Carter from Amsterdam presented some, and the highlight message was that the patients who got to the 2-year time point, and that wasn't everyone, that was about 3/4 of the patients who got to that time point and then stopped drug, 2/3 of those remain free of any evidence of progression 2 years later.
It's incredible. And a lot of, I'm looking at all the CLL abstracts that have come out at EHA. It is all about sequencing, and it's all about mixing these very powerful novel therapies and what's the best combination. And I mean, if we talk about, CLL 14, for instance, this fixed duration venetoclax, obinutuzumab for untreated. Previously untreated, so treatment naive patients are getting the opportunity. Do you want to talk about the results that are coming out of that?
Yeah, and so this was a really important study from the German CLL study group, a great group of investigators, and this was now the 3-year update of that information. It's been published in the New England Journal of Medicine, and this led to the registration in Europe and in the United States. Not yet here in Australia. Discussions are ongoing with the combination of venetoclax and the newer antibody obinutuzumab. And in the frontline setting, this is limited to 12 months of treatment. Morano in the relapse setting with a different antibody, 2 years of treatment. Now, which is the right one in terms of duration and antibody partner? There's still things being worked out. This update gave more information around what happens after ceasing treatment. Again, some mixed message, that's probably being a little unfair. A number of different take-home messages from this. The first was that overall, the whole population is doing well. About 80% of the patients, even 2 years after stopping the 12 months of treatment, remain free of progression of their CLL. That's great. This was in an older and frailer group of patients, and as we all get older, have the privilege of aging, other things tend to happen. So one of the possibilities is how much of this is a CLL issue and how much is simply that these patients were older and frailer. But one of the subgroups, so-called deletion 17p, so this group of patients with deletion on chromosome 17p that affects the p53 gene. We know with chemoimmunotherapy that's an undesirable and relatively ineffective treatment for deletion 17p. So all of the novel agent classes are more effective than chemoimmunotherapy, but deletion 17p probably still doesn't do as well even with the novel agents. In CLL14, a small group of these deletion 17p, and here's where the age and other issues come to mind, because it's not clear were they other problems or was it CLL progressing, but those with deletion 17p are not doing as well. So some questions emerging in the field: is 12 months enough treatment for this adverse risk group deletion 17p? Or, as you sort of alluded to with your introduction, is this a group where adding a third drug, another targeted agent such as a BTK inhibitor, might be preferred for that high risk group? There are a number of studies looking at using both across the board, and personally I'm not convinced that that is yet ready for prime time. You do seem to get slightly deeper responses, and maybe it may prolong things a little longer, but as you talked about with sequencing, and as I alluded to with taking a long-term view, if you've used both of your strongest weapons up front, what do you then do second line? And there's now good data that going from venetoclax to a BTK inhibitor works well, and previously very good data showing going from a BTK inhibitor when things, next treatment is needed, to venetoclax go well. So encourage people to take a long-term view, and it's not just what might be better in 1 year or 2 years, but what will have me the healthiest in the next 10 years.
And that's it. I mean, we've only got at the moment the one BCL2 inhibitor, but we've got a number of BTK inhibitors. And now, there's one of the papers I saw was comparing acalabrutinib to ibrutinib. And it looks like acalabrutinib, fewer side effects, more efficacy. So do you want to talk a little bit about that comparison?
So this is the class of drugs called BTK inhibitors, or inhibitors of Bruton tyrosine kinase. And ibrutinib was the first cab off the rank. And even though we call them BTK inhibitors, and all of these drugs do inhibit BTK, they are not as precise and targeted as perhaps we may like. And they also inhibit other enzymes, other what are called tyrosine kinases within the cell. And that might have some benefit in terms of treatment. It might increase the risk of side effects, and I think that's now becoming clear that the cleaner the drug is, the more tightly it targets BTK and not other things, the fewer the side effects. But also we may talk about, in terms of if you are combining it with another drug, a cleaner agent seems to have better benefits when combined with antibodies. So the first drug was ibrutinib, and it is a very effective and usually a well-tolerated drug. Now remember, what we're talking about is going from good to better to best. And we are never satisfied with what we currently have, and we always want to do better. So none of this is to say ibrutinib is a bad drug, because it is not, but we always want to do better.
And thank goodness, I mean, ibrutinib's our oldest novel therapy. Thank goodness it's been there.
Yes, absolutely. So acalabrutinib is a drug that is cleaner. We In another disease, we have a head-to-head comparison, so a direct randomised study, and that's the best way to compare these. But at EHA, there are also some indirect comparisons. And acalabrutinib is, to my view, at least as effective against CLL. And if patients are able to stay on drug longer, because there are fewer side effects, less diarrhea, less muscle aches, fewer risks of irregular heartbeat, atrial fibrillation, fewer cardiac complications. One of the things we're seeing in the long term is increased risk of blood pressure and the things that go along with that. Acalabrutinib has fewer of those side effects. So if somebody is able to stay on the drug longer, and we're seeing that with acalabrutinib, that around about 15%, so about 1 in 8 people need to stop the drug because of unwanted effects. In the real world, so outside of clinical trials, with ibrutinib, it could be as high as 1/3 or slightly even more of patients who ultimately need to stop drug because of side effects. So acalabrutinib appears to be the more effective drug, perhaps because it's better targeted, but certainly because patients have fewer side effects and can stay on the drug longer. And it seems to combine better when you're exploring recipes with other drugs, particularly the anti-CD20 antibodies, so things like rituximab and the other antibodies, obinutuzumab.
And where are we with acalabrutinib? Is it still, in Australia in particular, is it still only available in clinical trials?
Yes, there are a number of clinical trials of acalabrutinib going on in Australia, some in the frontline setting and some in the relapse setting. Acalabrutinib does have commercial registration, so the Therapeutic Goods Administration has said, yes, this is safe, this is effective, it's quality manufacturing. The next step is reimbursement, and it's not yet reimbursed by the government, so it's not yet on the Pharmaceutical Benefit Scheme, the free list, but I'm confident that that will follow.
And another weapon that we've got coming through is Zanabruton.
Yeah, so this is the third drug in that same class of BTK inhibitors. Zanubrutinib, made by a company called BeiGene, and a number of Australian investigators were pivotal in doing the early phase studies. The first people in the world were treated with this drug here in Australia, so it's dear to our hearts. But yes, it appears to have similar, what we would call a clean side effect profile. That doesn't mean it is free from any side effects, but the side effects appear fewer and less severe than with ibrutinib. There was a direct comparison of effectiveness in another disease called Waldenstrom's macroglobulinemia, so an indolent lymphoma, where zanubrutinib did not prove to be superior, but that gave us an ability to look at the side effect profile. And similar to what we were speaking about with acalabrutinib, zanubrutinib had fewer severe side effects than ibrutinib. Again, in the range of things that were improved were diarrhea, the muscle aches and pains, and the heart issues, irregular heartbeat, high blood pressure, etc.
Now, you mentioned some of the other lymphomas, and I shouldn't be selfish and just talk about CLL as much as it is dear to both our hearts. EHA, I mean, we've got a lot going on in terms of CAR-T, and we've discussed that with others. But in particular for follicular lymphoma, ZUMA-5 is really exciting.
Yes, early days, but I agree with you that the initial signal is very exciting. So CAR T cells, you know about a living drug. The immune cells are taken from the patient and very complex manipulation with new genes inserted, and these cells are then expanded billionfold and given back to the patient as a living drug. And they have the capacity, the potential, and as my grade 3 primary school teacher said to me, not everyone fulfills their potential, but they have the potential of reacting against the lymphoma cells. Now, this study, ZUMA-5, was in patients with follicular lymphoma who had received at least 2 previous treatments. So they had to have had what we considered to be standard treatments with chemotherapy drugs and with antibodies like rituximab or obinutuzumab. On average, they'd actually received 3 previous treatments, so things weren't looking so favourable for these patients. And in fact, more than half of them, their disease had progressed within 2 years of their initial treatment, so-called progression of disease within 24 months, or POD 24, identifies a group of patients where unfortunately our available treatments don't tend to do well. Despite all of these factors, nearly 90% of these patients, their disease shrank away with the CAR T cells. Now, this was not without complexities, and there's the cost that the registered drugs, and these drugs are registered for other diseases, cost about $500,000 to the community. So there's expense, there's logistics. Cells need to be collected, they need to be shipped around the world, they need to grow up, they need to be shipped back. These are complex and demanding practicalities, but also side effects. And there were some deaths from adverse events. And even though they weren't fatal, what's called cytokine release, where the immune system gets so activated and so revved up that it causes fevers, low blood pressure, shivers, shakes, sweats, potentially irregular heartbeat, and a less well explained set of symptoms called neurotoxicity, where people become confused, their memory is impaired. And to my concern, about 15% of people had relatively severe neurologic, so these brain side effects. Now, in other diseases, these CAR T cells have proven the ability to cure the disease. And so those side effects, those costs, those complexities are certainly, for many people, justified and appropriate where cure is achieved. Here's my uncertainty with ZUMA-5. The follow-up of these patients is under 18 months so far. And about 80% of patients achieve a complete remission where we can't see any lymphoma. And so far, those complete remissions appear durable. So at 12 to 18 months, 80% of that 80% are still in remission. So very encouraging, but at least from my perspective, this won't really be, at least in the Australian context, considered fundable and cost-effective for our community unless these remissions are truly durable and potentially show the capacity for cure. So yes, very exciting, wonderful response rates, but still early days. And if we don't know, if the lymphoma comes back in all of these patients at 2 years or 3 years, is it worth it in all of those domains? Whereas if there's a significant proportion who are cured, then I think it's very much worth it.
And that's what we were talking about a little bit earlier, about the importance of testing and being able to stratify high-risk patients for what are still risky procedures. And that's why you should always ask your doctor about clinical trials. We're very, very fortunate in Australia that, as you can see, we've got some of the best doctors in the world. We do get these clinical trials. You know, it is very important. Lymphoma Australia is a great resource for access to the latest information on clinical trials. We certainly try to stay up to date. And you ask your doctor. Ask your doctor about the tests they should be aware of. I mean, what would your advice be to patients who are tuning into this because they're interested in the latest science and these novel therapies that are coming down the line? We will not see them here for many, many years being funded. What would your advice
So clinical
be?
trials are the mechanism to potentially access these promising therapies. We're in a really good position with all of these leukemias or lymphomas that for the majority of patients, and particularly those with good prognostic factors, our current therapies are very effective. So the first question is, know your disease and know as much as you're able to your personal, your individual risk factors. And that comes down to stage of disease. It comes down to the conventional prognostic factors, and they vary by disease. But for example, in follicular lymphoma, how bulky is the disease? How big are the lymph nodes? Some of your blood test results, a thing called your LDH or your beta-2 microglobulin, how high are those? Is your bone marrow involved? And all of these things are able to give you a more detailed overview of how favourable or unfavourable your outlook may be with conventional treatments. And you, as an individual, can then weigh up, am I satisfied with that? What does a conventional treatment have to offer me? Am I at ease with how favourable that outlook is? If not, then the question comes up, well, what are the potential risks and benefits of a clinical trial? How likely is it that that drug will be effective against the particular profile of my disease? And that's where these molecular or so-called genomic features arise, where things like P53 that we're talking about, that in both follicular lymphoma and we may come on to mantle cell lymphoma as well as CLL, some of these identify a very small group of patients, but for that group of patients, their outlook with conventional treatments is far less favourable. So don't be satisfied with what may occur, being advised what may occur for the typical patient. Say, well, am I the typical patient? What is my profile? What are the individual characteristics of my disease?
And you've prompted me. I better ask about the OASIS study in mantle cell lymphoma. Yeah, that was an interesting paper as well that's been published.
Yes, so mantle cell lymphoma, a very infrequent form of lymphoma, only makes up 6%. But again, if you have that, then for you it's the most important form of lymphoma. And this is a frustrating disease for patients, and I'm sure for doctors, where initial response to treatment with the majority of things is relatively good, but it has an insidious pattern of relapsing. And unlike follicular lymphoma and unlike CLL, with our conventional treatments, it's a very small minority of people who have very durable disease control. Now, Contam here in Melbourne in Australia did a fantastic study combining two of the targeted agents that we'd talked about before, venetoclax and ibrutinib. Both of these have moderate activity in mantle cell lymphoma, but bringing them together in combination was a dramatic advance and achieved very deep remissions where we couldn't detect any disease, even using the most sensitive techniques. This study, the OASIS study, from two very good friends of mine, Steve Leguilde in Nantes in France and Simon Rule, who was in the UK, took things a step further and used the three classes of most active targeted agents: venetoclax, ibrutinib, and the anti-CD20 antibody obinutuzumab. And in a really carefully structured way, began step by step and showed the safety of adding the two together and then the three together. And this presentation was, if you like, the culmination of where this study was leading to. So using the three together in patients with mantle cell lymphoma who had not had previous treatment, so first line treatment. Only 15 patients so far, so small numbers, but the responses were stunning.
And fixed duration, how long were they?
Yes,
yeah.
And again, Thank you for prompting me. Yes, this was 2 years of treatment, and one of the drawbacks with either using ibrutinib on its own or venetoclax on its own in this disease is that both require continuous treatment. And unlike in CLL, where going from one to the other is quite effective, in mantle cell lymphoma, once your disease is resistant to one of these drugs, you get very little benefit, not zero benefit, but less benefit going to the other. So this was 2 years fixed duration treatment, previously untreated patients, and the complete remission rate was very high, about 80%. But more impressively, when they looked by this testing called MRD, or minimal residual disease, by a PCR test that was able to find, if it were present, able to find 1 cell in 1 million. And all of the patients had undetectable minimal residual disease. Wow. Still early, but 95% of the patients, their disease remains under control beyond a year of treatment. So a little bit like Zuma 5, again, very early, but this does appear to really have what we call synergistic. So the benefit of adding these together is far more than adding 1 + 1. Here we have 1 + 1 + 1 = 10, rather than 1 + 1 + 1 = 3. So early days, but dramatic benefit, very well tolerated treatment, and that has rapidly moved into randomised studies comparing the combination to ibrutinib alone.
Fantastic, and that's what I love about this. It's every 6 months, but the data just keeps on coming. It's never a good time to have lymphoma, but we are very, very lucky with the amount of drugs and novel therapies coming through in this area. So thank you for all the work you're doing. We'll continue to update you. EHA will be carrying on this week. Donna and I will be continuing to speak to other doctors, and thank you for joining us, and we look forward to bringing you the latest data, and you and I will speak again in 5 months' time, probably still in this studio, because we're not going to be in San Diego for ASH, I don't think.
No, we'll be safe and here in Australia.
Thank you.